secondly AntiAmoeba dispar, then Moshkovskii and Bangladeshi, and the most common is the AntiAmoeba histolytica. How this infection spreads, this is basically spread by the fecal-oral route. Whenever a person takes infected food by the cyst, then this infected food, when taken by the person, it goes to the stomach. This infected food is having cysts in it. Cysts of the AntiAmoeba histolytica. So in the stomach, this AntiAmoeba histolytica, these cysts are resistant to the acid of the stomach. So they travel through the GI tract, small intestinal tract to the large intestinal tract. So in the small intestine, these cysts are these cysts liberate the trophozoites. So this process is called excistation. A large number of trophozoites are released in the small and large, mainly in the large intestine, and these trophozoites may invade the intestinal wall by invading the mucous membrane. When there is invasion of the intestinal mucosa, these trophozoites enter into the wall of the intestine, and these also can travel through the blood into different organs of the body. For example, the most common site is the liver and lungs, as well as in the brain. So this infection may spread into the tissues and into the blood. When these trophozoites are present locally, not invading the mucous membrane, this infection is called local infection. So when these are invading, causing the development of the symptoms, these symptoms may be bloody diarrhea and also having mucus in the stool. And patient complains often on cramping of the abdomen. Abdominal cramps are there. And when these trophozoites enter into the liver, into the lungs, and to the brain, these trophozoites may cause abscesses at these sites. So when there is infection, the cysts and trophozoites are released into the feces, and whenever any person having may cause infection by handling the food or water, and whenever the person takes this infected food, he can get the infection. So basically, we can divide categorize the patients into two, mainly asymptomatic or symptomatic patients. Asymptomatic patients are in most of the cases, carriers. They are passing the cysts and trophozoites in the feces. And symptomatic patients are having symptoms. For example, symptoms like abdominal pain and diarrhea and stools having mucus and blood in it. The symptomatic patient can be categorized into mild to moderate, or severe cases. In mild cases, the patient is having loose stools and stomach cramping. In mild to moderate cases, the patient is having dysentery. Dysentery means stools having mucus and blood in it. Then are the severe cases. In severe cases, the patient is having the abscesses in the lungs and the brain, and most common site is the liver. How will you classify the amebicides or the drugs which can treat this condition? Firstly, the chemical classification. Chemical classification में सबसे पहले जो ग्रुप है वो नाइट्रोमिडाजोल्स. नाइट्रोमिडाजोल्स में जो important agents हैं वो metronidazole, tinidazole and ornidazole. Metronidazole is the most important agent frequently asked in the examination. Secondly, dichloroacetamide. In this, one drug is included, diloxanide furoate. Then is halogenated hydroquinolines, and hydroxyquinolines में एक agent आता है idoquinol. Then are the emetines. Emetines में दो agents हैं, emetine and dihydroemetine. Then are the quinolines. Quinolines में एक agent हम rarely use करते हैं वो for severe cases, that is chloroquine. And the next group is antibiotics. Antibiotics or antimicrobials. Among these, tetracyclines, paromomycin, and erythromycin are used to treat this condition. These agents are added with the other systemic amebicides. Then you can classify these agents clinically. Firstly, luminal agents. Luminal agents are mainly acting in the lumen and killing the cysts and trophozoites in the lumen. These luminal amebicides are diloxanide furoate, idoquinol, paromomycin, and systemic agents are acting systemically whenever there is infection present in the tissues or in the blood. So dihydroemetine or emetine and chloroquine. Then are the mixed agents. These are the nitromidazoles, metronidazole, tinidazole, and ornidazole. We can use these drugs in combination. For example, we can combine metronidazole and paromomycin and metronidazole or tetracycline. You see in this diagram, the luminal amebicides are mainly acting at the luminal site, killing these cysts and trophozoites, and these are this is the site of action of the systemic amebicides, killing the trophozoites in the luminal wall, in the wall of the intestine. And then are the mixed amebicides. These amebicides acting locally as well as the systemically. This classification is given in your big capsule, and we divide these drugs according to the symptoms of the patient. Firstly, if the patient is asymptomatic, there are no symptoms, you can give only the luminal agents. And these luminal agents are diloxanide furoate, idoquinol, and paromomycin. So whenever the patient is carrier or asymptomatic, you can give these luminal agents. Then next category is mild to moderate intestinal infection. In this condition, you have to give the metronidazole or tinidazole. Tinidazole और मेट्रोनिडाजोल के साथ आपने ऐड करना है ल्यूमिनल एमेबिसाइड, क्योंकि जब तक आप ल्यूमिनल एमेबिसाइड नहीं देंगे कंप्लीटली जो इन्फेक्शन है वो इरेडिकेट नहीं होगा. सो मेट्रोनिडाजोल or trinidazole, and add luminal, any luminal amibicide with it. The alternate drugs are the luminal amibicide, plus you can add the antibiotic. This antibiotic may be tetracycline or erythromycin. The next clinical scenario is if patient is having severe intestinal infection. Then again, the same drugs, metronidazole or tinidazole, and you will add luminal amibicide with them. The alternate therapy, again, luminal, you will give luminal amibicide plus tetracycline or dihydroamidine or amidine. You are adding these agents because now the patient is having severe infection. Next scenario is when the patient is having hepatic abscess, amoeboma, or other extra intestinal disease. Again, you will give the metronidazole or tinidazole, plus you can add the luminal amibicide. And alternate therapy is dihydroamidine or amidine, followed by chloroquine plus luminal amibicide. So these are the drugs which you can give when you see that what is the patient's condition. According to the condition of the patient, you can give these drugs. You have to remember only the dose of the metronidazole because it is the important drug, and we give metronidazole in almost all cases of these scenarios. Now, what is mechanism of action of the metronidazole? Metronidazole is basically acting in the active in the anaerobic conditions, anaerobic protozoal infections or anaerobic bacterial infections. This metronidazole is effective. And what happens when you give the metronidazole? It enters into the bacterium or protozoa, and the nitro group of the metronidazole is get reduced. How this is reduced? These bacteria, anaerobic bacteria or parasites, are having pyridoxine-like electron transport proteins. These proteins are participating in the electron transport reactions and giving the electrons. So this metronidazole, the nitro group of the metronidazole, is taking this electron and get reduced. When this metronidazole is reduced, it becomes cytotoxic to the bacterium or protozoa. And what happens then? This cytotoxic compounds bind with the DNA, and DNA and proteins are fragmented. So this is the mechanism of metronidazole. These are the steps. You have to remember these steps of mechanism of action. Some anaerobic protozoal parasites possess pyridoxine-like electron transport proteins that participate in metabolic electron removal reactions. The nitro group of metronidazole is able to serve as an electron acceptor, forming reduced cytotoxic compounds. This is active compound. This reduced cytotoxic compound is active compound that binds to the proteins and DNA and resulting in the cell death. So metronidazole is equally effective against the dividing and non-dividing parasites and bacteria. Now, what is the spectrum of activity? Metronidazole is effective against the anaerobic protozoal parasites and anaerobic bacteria. अगर हम anaerobic gram-negative bacilli को देखें तो उनमें basically this agent is active against bacterioid species, Fusobacterium and Veillonella. Among anaerobic gram-positive cocci, Clostridium, Bacterium, Peptococcus, and Peptostreptococcus. As already you have learned that the metronidazole is given to treat the H. pylori infection. You have learned the different regimens which we give to treat the acid peptic disease caused by the H. pylori infection. So this agent is also effective against the H. pylori infection, Entamoeba histolytica, Giardia lamblia, Trichomonas vaginalis. Excuse me. This agent, metronidazole, is active against the trophozoite state of the Entamoeba histolytica and has limited activity against the encysted forms. What is pharmacokinetic of the metronidazole? The preparations available are oral, most commonly used. The oral preparations are commonly used. Then intravenous injection form, then intravaginal gels and creams form, and topical form if the patient is having a topical infection. This metronidazole is usually completely and promptly absorbed and have well penetration into all body tissues, specifically vaginal secretions, seminal fluids, saliva, breast milk, and also in the cerebrospinal fluid. So this agent is well absorbed and completely absorbed when you give by any route. Peak plasma concentration reaches within 1 to 3 hours. The plasma protein binding of both drugs is low, that is 10 to 20%. There's difference in the half-life of the metronidazole and tinidazole. The half-life of metronidazole is 7.5 hours, whereas that of metronidazole is 12 to 14 hours. It means that the dose you have to you can give less doses for tinidazole, and you have to give the metronidazole thrice a day. It means that the dose of the metronidazole is thrice a day and that of tinidazole is BD. It means morning and evening. This drug is mainly metabolized in the liver, and if there is disease of the liver, its metabolism can be reduced, and this is mainly excreted in the urine through the kidney. What are the therapeutic indications of the metronidazole? Very, very important uses of the metronidazole. First use, as I have already told you, is that amoebiasis in hepatic and intestinal infections, then trichomolar infections in men and women, giardiasis, then anaerobic bacteria, serious infections caused by the Bacteroides fragilis, Clostridium, Fusobacterium, Peptococcus, Peptostreptococcus species. Then another important use is antibiotic-induced diarrhea, as you have already told by Madam Saida, that if you give penicillins to the patient, a condition developed called the pseudomembranous colitis, usually caused by Clostridium difficile. So this pseudomembranous colitis is treated by giving the metronidazole. Pseudomembranous colitis this condition can occur if you give the penicillins, fluoroquinolones such as ciprofloxacin, levofloxacin, and clindamycin. If you give these antibiotics, pseudomembranous colitis can occur, and you can treat this condition by giving the metronidazole. Then next use is in mixed aerobic and anaerobic infections. In anaerobic infections के लिए तो आपने देना है साथ अगर एरोबिक है तो आप कॉम्बिनेशन में दे सकते हैं, एंटीबायोटिक फॉर एरोबिक infection plus you add the metronidazole. And next use is H. pylori associated peptic ulcer disease, as I have already told you. Next use, bacterial vaginosis, different conditions, vaginitis due to different bacteria. You can give metronidazole to treat the bacterial vaginosis. Then periodontal infections, dental conditions, different dental infections, you can give this metronidazole. Next use is as an adjunct in the treatment of acute necrotizing ulcerative gingivitis caused by the spirochetes, fusobacteria, and bacteroides species. This condition is the inflammation of the gingiva. So this condition can be treated by giving the metronidazole. Next use is rosacea. This is inflammatory condition causing papules, pustules, and erythema. And this condition can be treated by giving the metronidazole. Then are the adverse effects. These are also very important. These adverse effects are severe, rarely severe enough. The most common adverse effects are related to the GIT. These GIT effects are, number one, metallic taste. Metallic taste, the patient feels that a coin is placed on the tongue. So the metallic taste is most common adverse effect of this agent. Then is furry tongue, nausea. Nausea can occur commonly, dry mouth, glossitis, stomatitis, as well as vomiting, diarrhea, and abdominal distress. Abdominal distress means heaviness and pain in the upper abdomen. This is picture showing the adverse effects of the metronidazole. Number one, nausea, GI disturbance, and then metallic taste. Next, adverse effects related to the kidney. The urine of the patient may become darker. CNS effects are there: headache, dizziness, vertigo, and encephalopathy, convulsions, incoordination, and ataxia. Incoordination, ataxia means imbalance of the patient's body. Convulsions are the fits, and encephalopathy are the different conditions, diseases of the brain. Then next adverse effect is blood, related to the blood, and there can be decreased number of the neutrophils, and this neutropenia is mostly temporary. Then what are the precautions which you will observe while giving the metronidazole? If the patient is already having history of sensitivity, then you should have to be careful. And if while giving this drug, the patient develops urticaria, flushing, pruritus, then you have to stop the drug. Then if the patient is having active disease of the CNS, then you should be careful while giving this metronidazole. Then severe hepatic disease, because this is mainly metabolized in the liver. So if patient is having liver disease, you have to be careful. Drug interactions, very important, often asked in the examination, drug interactions of the metronidazole. Firstly, disulfiram-like effect. What are these effects? Basically, in this condition, the patient is having facial flushing, headache, vomiting, and abdominal distress. Why it happens? Whenever patient is taking alcohol, and we want that he should stop taking alcohol, we treat the alcohol dependence by giving the agent called disulfiram. This is disulfiram. Basically, when patient takes alcohol, it is metabolized and acetaldehyde is formed. And from acetaldehyde, the acetate is formed, and then water and carbon dioxide is formed. This is basically a normal mechanism of the alcohol. And the enzymes involved are firstly alcohol dehydrogenase, which converts ethanol into the acetaldehyde, and the aldehyde dehydrogenase enzyme, which is converting acetaldehyde into the acetate. So when you give disulfiram, it is basically inhibiting the aldehyde dehydrogenase. What happens that there is accumulation of the acetaldehyde in the body, and because of accumulation of this agent, the patient is having facial flushing, vomiting, and headache. And patient don't want to take the alcohol and make it alcohol intake. So this is also when patient takes metronidazole. Metronidazole is actually inhibiting the aldehyde dehydrogenase enzyme, like that of disulfiram. When this enzyme is inhibited, what will happen? There is accumulation of the acetaldehyde in the body, and the patient is uh, experiencing the same symptoms like abdominal distress, vomiting, facial flushing, or headache. Next drug interaction is with lithium. If the patient is taking lithium along with metronidazole, or already taking lithium and you prescribe metronidazole with it, so there will be signs of the lithium toxicity. What happens that metronidazole is an enzyme inhibitor. So the enzymes which are metabolizing the lithium, those enzymes are inhibited, and the levels of the lithium is raised in the blood. So there may be lithium toxicity if you prescribe metronidazole along with it. Then is drug interaction with the somatotene. Plasma levels of metronidazole elevated. How elevated? Because somatotene is also enzyme inhibitor. It will inhibit the metabolism of the metronidazole. So there can be raised levels of the metronidazole. Then coumarin anticoagulants. The drug interaction with coumarin anticoagulants, the effect of these anticoagulants are may be increased. So when the levels of the coumarin anticoagulants are raised, there may be prolongation of the prothrombin time. Then next interaction is with phenobarbital or phenytoin. These are actually the enzyme inducers. So what happens? They metabolize metronidazole more and more, and we need more dose of the metronidazole. If there is more metabolism of the metronidazole, then there will be increased elimination of this compound. So these are the drug interactions of the metronidazole. Next agent is tenidazole. What is the difference between, the examiner may ask from you, what is difference between metronidazole and tenidazole? And there are two major differences. One is the tenidazole is having better toxicity profile. It means that there are less toxic effects with tenidazole, and it is having simpler dosing regimens. So you can give this agent in BD dose, morning and evening, and the dose of the metronidazole is usually given orally. It should be given thrice a day. Next agent is diloxanide furoate. Diloxanide furoate हमने पढ़ा था कि this is the luminal imidazole. So diloxanide is actually dichloroacidamide derivative, and it is drug of choice for asymptomatic luminal infections. Mechanism of action of this agent is unknown, but if we see its pharmacokinetic, what happens when you give the diloxanide, it is splitted into the diloxanide and feroic acid. The absorbed diloxanide conjugated with the gluconide and excreted in the urine, whereas unabsorbed diloxanide is active anti-amoebic substance. क्योंकि ये absorb नहीं होगी, locally present होगी colon में, तो वहां से इसकी locally sorry तो इसकी concentration जब ल्यूमन में ज्यादा होगी तो ये locally active होगी. Therapeutic uses क्या होंगे इसके? Asymptomatic passers of amoebixis, and it is used along with or after an appropriate systemic or mixed amebicide. Systemic और mixed के साथ आपने ऐड करके देना है इसको, जैसे हमने अभी पढ़ा था different clinical scenarios में कि आपने कैसे इन agents को देना है. और उसके अलावा अगर कैरियर है पेशेंट, पास कर रहा है सिस्ट एंड ट्रोफोजॉइड्स, तो उस केस में आपने, और पेशेंट एसिम्प्टोमेटिक है तो उस केस में आपने डाइलॉक्सानाइड को प्रिस्क्राइब करना है. Adverse effects of diloxanide are usually mild flatulence, nausea, vomiting, and diarrhea, and urticaria are the common adverse effects of this agent. Next agent is emetine and dihydroemetine. These compounds are given in severe cases of the amoebiasis, or if metronidazole is contraindicated, then you can use these agents, emetine or dihydroemetine. Emetine is an alkaloid derived from the ipecac root. It is basically a systemic amoebicide, and this agent emetine is more toxic than the dihydroemetine. Dihydroemetine is a synthetic analog and better toxicity profile, and having better toxicity profile. Uses of emetine and dihydroemetine when metronidazole is ineffective or contraindicated. Pharmacokinetic of the emetine and dihydroemetine, these agents are administered parenterally, not orally, and preferable route should be subcutaneous. You can also give these agents intramuscularly, but in supervised setting. These agents accumulate in the tissues and are eliminated via the kidneys. Mechanism of action, basically these both agents inhibit the protein synthesis by blocking the chain elongation and ultimately stopping the growth of the parasite. Therapeutic indications, again, when the metronidazole can't be used or metronidazole is contraindicated, and secondly, it is effective for the trophozoite state of the Entamoeba histolytica. Adverse effects are generally mild and appears when the drugs are used more than 3 to 5 days. 10 days तक अगर आपने यूज की है ड्रग तो फिर इसके एडवर्स इफेक्ट्स जो है वो अपीयर होना शुरू होंगे. Usually these adverse effects are pain and tenderness in the area of the injection. Sterile abscesses may develop. Diarrhea is common, nausea, vomiting, and muscle weakness. And especially ECG changes are seen if these agents are used for longer duration. And these cardiac effects are cardiac arrhythmias, heart failure, and hypotension. So you should be very careful while giving these agents, emetine and dihydroemetine. And these agents should only be used when the metronidazole is contraindicated or patient can't tolerate metronidazole. What are the precautions while giving these emetine and dihydroemetine? You should not give these agents if patient is having cardiac or renal disease, in young children, and in pregnancy, and should not be used for more than 10 days. Next agent is iodocunol. As name indicates, this is iodine containing compound. This is also an luminal amebicide, and it is used with metronidazole to treat the amoebic infections. What is pharmacokinetic and pharmacological effects? 90% of drug is retained in the intestine and excreted in the feces, and 10% enters into the circulation. You see that 90% of the drug is retained in the intestine because this is having a local amoebicidal effect. Mechanism of action of this agent is also unknown, and it is effective against organisms in the bowel lumen. Precautions क्या हैं? अब precautions क्योंकि iodine containing compounds हैं, so you should be very careful while giving this agent. It should be given with meals, and you should be careful in patients who are having optic neuritis, renal disease, thyroid disease, and hepatic disease. And this agent should be discontinued if it produces persistent diarrhea or signs of iodine toxicity. And these signs may be dermatitis, urticaria, pruritus, and fever. Next agent is peromomycin sulfate. It is basically an aminoglycoside antibiotic, not significantly absorbed from the GI tract. And it is used as luminal amebicide. It may cause renal toxicity. In recent study, it was superior to diloxanide furoate in clearing the asymptomatic infections. अभी research हो रही है इस पे, and अब ये देखा गया है कि it is superior to diloxanide furoate in patients who are asymptomatic. What is mechanism of action? It inhibits protein synthesis by binding with the 30S subunit of the ribosomal protein and ultimately stopping the growth of the parasite. Adverse effects are abdominal distress and diarrhea, and avoid these agents if patient is having renal disease and GI ulceration. The last agent is chloroquine. This is basically an anti-malarial drug, and the mechanism of action, it is basically given whenever the patient is having a liver abscess caused by the AntiAmoeba histolytica. So this agent acts by concentrating in the parasite food vacuole and preventing the biocrystallization of the हाँ, इसकी बायोक्रिस्टलाइजेशन ऑफ हीमोग्लोबिन को प्रिवेंट करेगा और कन्वर्शन जो हीम से हीमोजाइम में हो रही है उसको ये प्रिवेंट करता है. तो व्हाट विल हैपन दैट देयर विल बी एक्यूमुलेशन ऑफ द हीम, and whenever there is accumulation of the heme in the cell, it will be damaging to the parasite. So this agent basically is used for the treatment of malaria, but we can use this agent whenever the patient is having liver abscess caused by the trophozoites of the AntiAmoeba histolytica. So these are the drugs, different drugs which we can use to treat the amoebiasis caused by the AntiAmoeba histolytica. And thank you very much. Any question you can ask.
Assalamu alaikum, ma'am.
Wa alaikum salam.
Ma'am, the first question is, what do you mean by tinidazole adverse effects are better tolerated than metronidazole, and why?
Tinidazole के जो adverse effects हैं वो कम हैं as compared to the metronidazole. So these agent is better tolerated in different patients. Patient to patient vary करता है, लेकिन इसका toxicity profile जो है वो better है. It means कि toxicity कम है as compared with the metronidazole.
ओके मैम, द नेक्स्ट क्वेश्चन इज
जी
कि जब आप सारी स्टेजेस डिफरेंट ल्यूमिनल बता रही थी और सारी डिफरेंट
जी
बता रही थी, तो
जी
उसके अंदर उन सब की डोजेस याद करना इम्पोर्टेंट है?
नहीं बेटे, अब मैंने आपको पहले बताया कि मेट्रोनिडाजोल क्योंकि प्रोटोटाइप ड्रग है तो उसकी आपने जो डोज है वो जरूर आपको आनी चाहिए, और वो एक ही डोज है 750 मिलीग्राम है, थ्राइस अ डे देना है, या अगर आप इंट्रावीनस दे रहे हैं तो वो आपने उसको 6 आवरली देना है और सेम डोजेस में देना है। तो वो आसान है आपके लिए याद करना, मेट्रोनिडाजोल की आपको याद होनी चाहिए डोज।
ओके, थैंक यू सो
नॉट
मच
ऑल
मैम।
एजेंट्स। थैंक यू वेरी मच बेटा। ओके।